So larynx cancer tidbits. The sites of the supraglottic larynx include the suprahyoid epiglottis, the infrahyoid epiglottis, the arioepiglottic folds, the arytenoids, and the false vocal cords. The glottis includes the true vocal cords plus or minus half a centimeter, i.e. it is 1 centimeter thick, including the anterior and posterior commissures. And then the subglottis is 0.5 centimeters below the true vocal cords to the inferior cricoid. Looking at a portion of the actual larynx itself, you need to orient yourself first by looking where the epiglottis is. That should be easily identifiable. Again, the true vocal cords are going to be the most medial whitish things, and then the vestibular or false cords are what are somewhat lateral to them. That's the glottic level. Behind them, you're going to see the cuneiform tubercles and the arioepiglottic folds, which are part of the supraglottic larynx. This gives you a good image here. So first orient yourself looking to see the epiglottis is here. The vallecula is going to be right in front of the epiglottis near the root of the tongue. Clearly we can identify here, these are your vocal cords or your vocal folds, and then the ventricular folds, vestibular false cords. Near here, just behind sort of where the epiglottis is, you'll recognize the arioepiglottic fold, the cuneiform tubercle, and the trachea can be seen down in there. Work up H&P with attention to hoarseness, KPS aspiration risk, nasopharyngolaryngoscopy, laterality involving the commissures, extension to adjacent sites, vocal cord mobility, CT neck with thin cuts throughout the larynx, and PFTs if you're considering surgery. Other images I just want to show you here. This is sort of a coronal view. The blue is supraglottic, red is glottic, yellow is subglottic, and then green is the trachea. Again, you can see the epiglottis here. Here's the hyoid bone separating the epiglottis and the supra. An infrahyoid epiglottis, which is part of the supraglottic larynx. You can see the vestibular folds here. There's the thyroid cartilage. The vocal folds are here. Cricoid cartilage is where everything ends. This is what a 5x5 field looks like for just an early stage larynx cancer. Again, in terms of staging, general T1 is confined to the site with normal mobility. T2 is an adjacent site or impaired mobility. T3 is fixed cord or paraglottic extension, pre-epiglottic space invasion, posterior cricoid invasion, or the inner cortex of the thyroid invasion. T4A is the same for all larynx. It's thyroid cartilage penetration through the cartilage, and it invades beyond the larynx to involve the trachea, the cricoid, the extrinsic tongue muscles, the strap muscles, the thyroid, or the esophagus. T4B is the same for all larynx and involves either the prevertebral fascia, encases the carotid, or invades mediastinal structures. For glottic larynx, the staging T1A is one cord, which is normal. T1B is both cords, which are normal. T2, it involves the supra or subglottis, or you have impaired cord mobility. T3, again, the cord is fixed, or it invades the paraglottic space or inner cortex of the thyroid cartilage. T4A and T4B are the same. Supraglottic larynx staging T1, one subsite, normal vocal cord mobility. T2, it invades one adjacent subsite or involvement in the surrounding regions, i.e. base of tongue, vallecula, or piriform sinus. T3 is PPTF, posterior cricoid space, pre-epiglottic space or paraglottic space invasion. TF, inner cortex of the thyroid and vocal cord fixation. Supraglottic larynx has a much higher rate of lymph node positivity than the glottis, and then the subglottis, T1, subglottis only. T2 is extension to the true vocal cords with normal or impaired mobility. T3 limited to the larynx with fixed vocal cord, or it invades the paraglottic space or inner cortex of the thyroid cartilage. In terms of management, general principles, T1 to 2 and 0 can be treated with radiation alone versus limited surgery like endoscopic or partial laryngectomy. T3 or T4 or node positive is generally managed with chemoradiation versus total laryngectomy plus or minus postoperative chemoradiation. Postoperative radiation indications are PT4, PT3 for supraglottis, N2 or N3, 7th edition, LVSI, perineural invasion, positive margin, positive extranodal extension. Postoperative chemo radiation indications are positive margin and positive extranodal extension. T4A disease, preference for upfront surgery, then postoperative radiation instead of chemoradiation. Glottic larynx, TIS, radiation 60 at 2.25 gray per fraction or endoscopic resection, followed by partial laryngectomy. Early T1 to 2 N0 glottic larynx cancer is treated with definitive radiation versus limited surgery. Definitive radiation for T1 is 63 gray, 2.25 gray per fraction times 28 fractions. For T2, it's 25.25, which is 2.25 gray times 29 fractions. So you just add on one more fraction. Alternatively, you do surgery with chordectomy or partial laryngectomy, vertical or horizontal. Local control, larynx preservation, overall survival, voice quality is roughly the same with radiation or surgery. If the T2 has extension into the supra or subglottis, treat the nodes as well. Levels 2 through 4. Advanced larynx cancer, T3 or node positive, chemoradiation per RTOG 9111, cis 100 milligrams per meter squared every 3 weeks, or Cetux 400 milligrams loading, then 250 every week. Your other option is total laryngectomy with lymph node dissection, and then radiation or chemoradiation is indicated. It is preferred that you treat things this way if it's a T4A tumor. Total laryngectomy removes the hyoid, the thyroid, the cricoid cartilage, the epiglottis, and the strap muscles. The patient is left with a permanent tracheostomy and a pharynx reconstruction by suturing to the base of tongue. It's most common to fail at the stoma, at the base of tongue, and the neck nodes. Your third option for advanced larynx cancer is induction chemo followed by radiation or surgery. Induction would be TPF, docetaxel, cisplatin 5-FU every 3 weeks times 3 cycles. If they have greater than a partial response, at least 50% shrunken, then treat with radiation alone. If they have less than a partial response, then do lymph node dissection. Treatment for supraglottic larynx cancer, T1, T2 is the same as above for glottis, radiation alone versus partial laryngectomy. For T3 to T4 or node positive, as above for glottis, chemoradiation if there's a functional larynx with low risk of aspiration. You do total laryngectomy with lymph node dissection and radiation or chemoradiation for high-risk features. Again, preferred if T4A. Then you do induction chemo, followed by radiation or surgery is your third choice. Subglottic larynx, definitive radiation for T1 to 2. T3, T4, node positive chemoradiation if there's a functional larynx with a low risk for aspiration. Total laryngectomy plus lymph node dissection followed by radiation or chemoradiation for high risk features, preferred if T4A. Let's go through the evidence for this. Evidence for early stage glottic cancer, Japanese Yamazaki 2006. This is T1, N0 randomized to either 2 gray per fraction or 2.25 gray per fraction. Minimal tumors less than 2/3 of the cord were treated 60 gray versus, 56.25. Larger tumors 66 versus 63 gray. Local control at 5 years was improved 77% versus 92%. There was no difference in overall survival or toxicity between these two arms. In terms of retrospective data for T2 tumors, local control is 80% with 65.25 and 29 fractions. There's also a Helsinki University Hospital trial looking at T1A larynx, 6 gray or carbon dioxide laser. Radiation is superior voice outcomes, there's less breathiness. For advanced larynx cancers, the VA larynx trial for organ preservation looked at stage 3 to 4 larynx cancers. They were randomized to either induction PF times 3 cycles, which is cisplatin, fluorouracil, followed by radiation 50 to 70 gray, or total laryngectomy plus node dissection, followed by 70 gray if they had a complete response or partial response. If they had no response, then they got a salvage total laryngectomy and post-op radiation. There was no difference in 2-year overall survival between these two arms, 68% for both. Approximately 2/3 of the patients had a successful organ preservation. Local regional recurrence is 20% with larynx preservation. Predictors of salvage laryngectomy were T4 tumors. 56% needed laryngectomy versus 29% of less than T4. Bottom line from the V-Larynx trials, organ preservation is feasible. It maintains overall survival outcomes at around 68% and has better long-term quality of life. The next trial is RTOG 9111, Forestier, JCO 2013. Stage 3 or 4 larynx cancers. You had 3 arms: induction chemo and radiation, concurrent chemo, radiation, and radiation alone. This excluded T1 and T4 with greater than 1 centimeter in the base of tongue or through the cartilage. Larynx preservation was increased from 66% to 82% with chemoradiation. Local regional control is improved from 50% to 66% with chemoradiation. Concurrent chemoradiation improved local control but not overall survival. Overall survival at 2 years was 75%. Chemoradiation is the best for larynx preservation, local control, local regional control, but there's no difference in LFS, distant control, disease-free survival, or overall survival. Next trial is Gore-Tex, stage 3 or 4 larynx or hypopharynx, 50% hypopharynx. Either got PF times 3 followed by radiation or TPF times 3 followed by radiation. Required at least a partial response with vocal cord recovery to be eligible for radiation. The improvement eligible for radiation, 60 to 80%. For PF versus TPF, 3-year larynx preservation, 60 to 70%. Overall survival at 3 years was 60%, no difference. The Tremplin study, Lefebvre, JCO 2012, looking at induction TPF followed by cis radiation versus Satux radiation. No difference in overall survival, larynx preservation. Higher local recurrence in Satux, but salvageable. In terms of techniques and planning, glottic T1 to T2 and 0 fields. T1 gets a 5x5 field, T2 gets a 6x6. You put the ISO at the true vocal cords. Superior border is the thyroid notch. T2. The superior border is going to be the inferior hyoid. The inferior border is the bottom of the cricoid. If it's a T2 tumor, it's the first tracheal ring below the cricoid. Anterior, 1C on flash. Posterior is the anterior vertebral body. Planning, do opposed laterals with 15 or 30 degree wedges. The heel should be anterior. Under wedge or bolus if the anterior commissure involved and plan is cold anteriorly. There's no elective nodes unless the supraglottic or subglottic extension is present. Then electively treat levels 2 through 4. Hotspot should be less than 110. You can kick the couch 5 to 10 degrees or rotate the gantry anteriorly if you're shooting through the shoulders. For T3 to T4, glottic, node positive, or any supraglottic, you do definitive IMRT dose painting, 70, 63, 56, and 35 fractions. Volume per NRG consensus in Nancy Lee book. CTV 70 is GTV primary and GTV nodes plus 5 millimeters. CTV 63 is levels 2 to 3 on the node positive neck. GTV primary plus 1 centimeter and GTV node plus 1 centimeter, or the entire larynx from the thyroid notch to the cricoid cartilage per Nancy Lee. The Nancy Lee version is probably easier to say for boards. Post-op larynx, CTV 60 is the op bed, the node positive stations. CTV 54 is the elective nodes. Least levels 2 through 4 stoma. Boost to 66 of positive margin or positive extranodal extension. Boost stoma to 60 of subglottic extension or emergent trach. For subglottic, first echelon nodes, bilaterals levels 2 through 4, and 6 cover stoma and high risk CTV in all cases. Toxicity and follow-up, overall survival at 5 years for larynx is 80%. Radiation local control is 90% for stage 2. 5-year overall survival is 60%. Radiation local control is 80%. For stage 3, it's 50%. For stage 4, it's 35%. Again, this is 5-year overall survival. Larynx preservation with radiation alone is 60 to 70%. With concurrent chemoradiation, it's 80 to 85%. Toxicity includes hoarseness, cough, dysphagia, dermatitis, laryngeal edema, cartilage necrosis, 5% with 70 gray, and hypothyroidism. From RTOG 9111, dysphagia and odynophagia is 15%. PEG tube dependency is less than 3%. Local control with radiation alone for T1 tumors, suprahyoid or supraglottic is 80%, T2 is 70%. One thing I will cover here is for supraglottic cancers. T2, you cover the pre-epiglottic space, the paralaryngeal space, including the thyroid cartilage, but cropped from the strap muscles. T3 supraglottic does not extend past the thyroid cartilage except if it's infiltrated. T4 supraglottic typically not past the strap muscles. CTV 56, levels 2 through 4 in the node negative neck. Level 6 is subglottic extension or hypopharyngeal involvement or gross level 4 nodes. And that's it.